teach them the 3 meals plus 3 snacks. Then late dinner to be avoided. If the client is taking the late dinner, the patient should not sleep immediately. The patient should walk at least 100 steps, then the patient should go for the sleep. Now, physical activity. So, the client has to set their physical activity, because in diabetic clients usually and always we are telling that you have to do the physical activity. So, whenever they are starting the physical activity, make sure that they are not the empty stomach and they have taken the insulin. So, if they have taken the insulin or oral hypoglycemic agent, they have to take some snacks, and also make sure if there are any symptoms of hypoglycemia occurring, they should stop their activity immediately. Then repetitive education is also essential, because those patients who have the diabetes after 4 year, 5 year, 10 year, so that will not be, those patients will not be much compliant on the nutrition and the activity. So, again the risk of hypoglycemia is increasing on those patients. So, whenever the patients are coming for consultation in hospital or in any healthcare facility, we need to educate them repetitively. Then therapeutic intervention. So, if the client is having the severe or repetitive episodes of hypoglycemia, so we have to change our therapeutic regimen also. So, change from pre-mixed insulin to split mix or basal bolus, because that will not cause the acute fall in the blood glucose level, and avoid sulfonylureas whenever possible if the patient is having the recurrent hypoglycemia. Then avoid drug which could mask the hypoglycemic symptoms or augment the hypoglycemia, for example sulfur drugs or quinolones. So, there are many drugs which may cause the hypoglycemia. Then always consider the glargine over the NPS, because this is a long acting drug. So, which which will not leads to acute fall in the blood glucose level. Then short acting analogous over human insulin should be preferred. Short acting insulins alone in the renal failure, and maintain suboptimal control in liver diseases. So, we need to keep in mind while planning our therapeutic regime. Now, compliance is a major issue involving the therapy of patient in India as well as in Asia, because we need to discuss these issues releases fast. If the patient is diabetic and the patient is taking the insulin and also patient is doing the fast, so this is the severe risk factor for developing the hypoglycemia. So, we need to educate the patient about the releases fast. If they are keeping the fast, they need to change their insulin doses. Then polypharmacy for the metabolic syndrome, for example, the many patients, they along with the diabetes, they are having many other problems where they are having multiple drugs, so which may in turn cause the hypoglycemia. Then insulin therapy and needle phobia. So, continuously if the patient is taking the insulin, so because of that the client will develop the needle phobia and will avoid taking the insulin. So, again that may cause hypoglycemia in the patient. So, what can be the consequences of this? So, first one is the delay in the treatment, which can result in profound sequelae, that is it can be coma, cardiac dysarrhythmia and even death. Then permanent neurologic deficits may occur if the client is having repeated or long episodes of hypoglycemia. The patient may have hemiparesis, memory loss, diminished language skills, decreased abstract thinking capabilities and also ataxia. So, in patient with cardiac autonomic neuropathy, death can occur, which is known as the dead in bed syndrome, DIB. So, these are my references for hypoglycemia and its management. So, today we have discussed in detail about the hypoglycemia in diabetes, what are the symptoms, how we can diagnostically evaluate the hypoglycemia and how we can prevent and treat the hypoglycemia. Thank you very much.